And then the second day, they actually see the social worker, and they see the physical therapist and occupational therapist for kind of
an update.
Yeah, a chance to sort of ask additional questions. I've now talked to the two therapists about the results from lab testing, EMG. So if it looks like, let's say, their arms are polio free, they can show them some of the equipment that's available for upper extremity exercise. It's also a chance to talk about wheel mobility, if that's an issue, or maybe using a cane or forearm crutch or whatever it might be. Because we find frequently on the first day folks are a little bit reluctant to make a change. I mean, sometimes very reluctant. I mean, they're in denial. They don't, they don't want to look disabled. They don't want to use that cane. They don't want to, But often by the second day, they've had a chance to sort of sleep on it. We encourage people to bring their spouse or significant other, someone they can talk to. So the evening is an important time for things to sort of percolate, for people to digest what they've heard, integrate it. And so they come back the second day, and they'll often have, a little different perspective and be more willing to hear different things and maybe even try different things. So that's why the second day is really critical, because we can already take that first step to doing some very specific management things. So it's not just all talk. And that's a really key part of the program, that we go from, evaluation to sort of plotting out a course of intervention, give the patient the time to digest it and be perhaps more ready to accept it, and then give them some very specific concrete things to do, to try out, right while the therapist is there. So it's not theoretical.
Mm.
And then, at the very end of the morning of the second day, we have a sit-down conference for half an hour with everybody who has seen the patient. So the therapist, the social worker, myself, patient, their significant other, and it's a time to just pull everything together.
Is the orthotist brought in at that point?
No, I'm sorry. That's a good point. The orthotist usually sees the patient on the first day. And because their contact, they don't tend to spend a lot of time taking a history, and usually the brace can't be manufactured, overnight. So mostly it's an evaluation and a recommendation, and then they might come back later to get a brace, fitted. But anyway, the closeout conference is really key because it sort of pulls everything together. And we review our findings, we review our diagnoses and our recommendations. And it's a chance for the patient and, say, their spouse to ask questions. And the reason I like to have everybody around the table is so that we're all sort of, reinforcing each other. And if the PT says something that, I don't quite agree with, we try to thrash it out right there, so the patient doesn't leave with mixed messages. And then, as we've talked about, there's a little sheet in which each of us lists our 2 or 3 key diagnoses and 3 or 4 of the key interventions. So the patient has something very concrete to take home with them. And then I dictate a report. I would dictate a report from the first day of my evaluation. And then the second day I do a dictation that summarizes the conference. So that gets sent to them in the mail a few days later. Again, so they have documentation, so they can read it, they can take it to other health professionals. So the whole idea is, really a strong emphasis on education. I didn't mention when the patient arrives. The nurse does a nursing assessment, and they present the patient with a packet of articles and information about the local support group, blah, blah, blah. So, the whole thing is to try to give the patient as much information as we can, hopefully not overload them, but do as thorough an assessment as we can given the time available, and then trying to integrate and make it all kind of come together. And I have to tell you that when people finish that conference, they inevitably say, "This has been absolutely extraordinary. This has been the best healthcare experience of my life."
One thing that I do need to know though is the day and a half clinic that you conduct here. If a person were to pay for that themselves, if they had no insurance as an example, what sort of cost would they be looking at?
The EMG tends to be expensive if that's part of the package. So it might be $2,000, $2,500.
Okay, so 2,500 for a 1.5 day session. But in this situation, virtually everybody is able to claim that on their health insurance. 100%?
Just about. Yeah, I mean, Medicare pays for it. I mean, one of the things that we've done is tried to make sure that the services we get are, kind of standard, like the physical therapy. I mean, the physical therapist charges for the time she spends with the patient. So there's nothing special about the polio patients in that sense. And my charge is the same as it would be for spending an equivalent amount of time with, say, a patient with spinal cord injury. So it's sort of dependent on the time and the complexity of the way it works out.
The next time, if they came back in, say, 3 or 6 months' time just for a follow-up, what would be the time spent with them on that occasion? Well,
usually the follow-up, they see me. I mean, they may have been in the interval seeing a physical therapist for whatever, or an OT. They may have been going to the wheelchair seating clinic. They may have been getting a brace. So they've seen other folks. But then my role is to sort of try to pull it all together. And then I might see them for 30 to 60